Okay, it is officially afternoon this Wednesday. It's so exciting. Everyone knows it is noon, May 10th. It is my honor to introduce Dr. Lauren Ashley Tipton, who completed undergraduate studies at Washington and Lee, where Dr. Tipton received a Bachelor of Science in Neuroscience and was Phi Beta Kappa. Dr. Tipton attended medical school at University of South Carolina, School of Medicine in Greenville, South Carolina, and completed residency in adult psychiatry at CPNC here in SF. She is now a CAP 2 fellow in the UCSF Child and Adolescent Fellowship. Dr. Tipton's discussant today will be Dr. Esme Schaller. She is a clinical professor in the UCSF Department of Psychiatry right here in Behavioral Sciences. Dr. Schaller received her BA in psychology with highest honors from UC Berkeley and her PhD in clinical psychology from the State University of New York, Stony Brook. She helped build the Wavefront Dialectical Behavior Therapy program here and expanded it from just 2 clinicians in 2007 to the program we have today. She is the clinical director of the Wavefront DBT Clinic and the past board president of the International Society for the Improvement and Teaching of DBT, also called Is It DBT, as well as a co-founder of the Is It DBT Anti-Racism Committee. Dr. Schaller's passion lies in teaching and dissemination of empirically supported treatments for complex psychological problems, particularly in adolescents. As such, she devotes a large percentage of her time to teaching and training, both within UCSF's residency and fellowship programs and in the larger Bay Area community. Very excited for this talk today. Please join me in a warm welcome. Hi. And I will go ahead and mute myself and pass the mic.
Awesome. Hi, everybody. Thanks for coming. My name is Lauren Ashley, and this is part of our CAP Fellow Grand Rounds. And the title of my presentation is Private Residential Programs for Youth to Refer or Not Refer. And I did have to add the disclaimer that this is a very difficult question to answer after spending copious amounts of time reviewing articles, academic and those in the lay press, examining controversies and abuse reports that should frankly inspire a new docuseries complete with legislative cover-ups by political figures that, well, I never saw coming, and simultaneously noting the existence of some actual good programs doing solid work for a very difficult patient population. I determined that there was no easy answer to this question of to refer or not refer. Instead, I'd like to bring you along for part of the journey of what I have discovered about the current state of this field. Our learning objectives today are as follows: defining 4 program types, identifying 3 milestones in the history that led to the development of private residential treatment centers, understanding the controversies related to safety, efficacy, and the maintenance of gains at private residential settings, and connect 2 limitations of our current knowledge base with the available literature. Of note, I don't have any disclosures to report. So why this topic? This is a pretty dangerous slide. I could easily spend the entire hour just talking about just the first half of the first bullet point here, which is personal experience with my first job. So just to paint a bit of a picture, I graduated college and was bright-eyed and bushy-tailed, had applied to medical school and was pretty excited about filling my gap year with something in the healthcare orientation, specifically when I came across a hiring ad for a patient advocate at a seemingly well-reputed facility. I enthusiastically applied and was ultimately thrilled to obtain the position. I thought I did my research. I studied the glossy website. You can see on your screen, this is the only remaining photo I can find of the facility that I worked at. This unaccredited facility was shut down a few years after I worked there and has essentially been scrubbed from the internet. I studied the glossy website with the color-coded schedule full of how patients' days were divided among therapy modalities, between doctor's appointments, 12-step meetings, and others, but no amount of research could have prepared me for my first day. I arrived for my first shift, and I saw the outgoing house manager who was leaving the home. He was on the way to the carport, but stopped for a moment to do some level of what we might term sign out, and let me know that he was running late. He worked full-time as a butcher at a local grocery store, but he paused long enough to tell me that one of the 5 patients at the facility, had a pretty concerning phone call this morning with his parole officer. And that after this conversation with the parole officer, the patient had been a little upset. And that the patient had essentially opted out of that day's activities, which included going to the beach. The outgoing house manager let me know, though, that all patients are expected to attend the evening AA or NA meetings. And I understood, and I went in the house. I met with all of the patients. And when I saw that patient, we'll call him Kyle, he was headed up the stairs to the patient's bedrooms. And I extended the invitation to Kyle to come with us to the beach. And he declined again, stating he was tired. He stated that he needed a deep sleep. I told him that we would see him later, and he smiled. He walked towards his bedroom and said, "Sure," as he nonchalantly walked away. What we didn't know was that this was the last time that Kyle would talk to anyone, as while we were at the beach, Kyle died by suicide by hanging in the shower. While the suicide initially appeared extremely sudden to me, in the following days and weeks, I learned that things were not as they seemed at the center that I was now employed. Those daily schedules filled with therapy and doctor's appointments, well, they didn't exist, and my patients didn't see therapists. In fact, in the 3 months that I worked there, I saw one therapist come onto the property one time. In addition, I also learned that in the weeks following or preceding the suicide, Kyle had been evidencing some really concerning behavior. He wouldn't go into certain rooms in the house because of a belief that bugged landline phones were in them. He had frank paranoia about electrical outlets, and it also came out that he had given away prized possessions like his grandfather's Rolex watch at an AA meeting in weeks prior. Despite all of this, and despite the program promoting itself as an excellent center for dual diagnosis care, no one took him for help. No one presented to a PCP, no one called 911, no one took him to urgent care. There was no psychiatry involvement, no psychologist was called. He was just labeled a weirdo by the other patients, and no one thought to do anything else. I realized that at the ripe age of 21, and with only a bachelor's of science, I was somehow the most clinically trained person at this facility. Following this harrowing experience, I developed a high level of skepticism towards residential programs. I didn't expect them to be a part of my life again until my 4th year of medical school rolled around. And this is the second part of that first bullet point, where during our elective rotations in our 4th year, I opted for a crowd favorite, which happened to also be a substance use disorder residential program that was in the mountains of North Carolina. This particular program was designed for professionals in recovery from substance use, specifically physicians, nurses, pharmacists, dentists, the like. And during my interim at this residential care unit, I had the exact opposite experience that I had had during my gap year. I witnessed gold standard quality of care. I saw patients in the detox center be treated swiftly and appropriately. I saw medication-assisted therapies being discussed and prescribed. I saw weekly team meetings where each patient was discussed in extraordinary detail by various providers who are coordinating their care. I met with alumni and families who would frequent the campus on weekends, and they would tell me about how their lives had literally been saved by the residential program. This was certainly a stark contrast from the life that I saw negligently claimed by my first place of employment. In addition to my first two experiences in residential, the issue has also come up since I've been a fellow here at UCSF. One of my rotations was at Edgewood, and I also got even more experience with advising whether or not patients should be considering residential when I inherited my current patient panel load. Specifically, I'll talk about briefly 3 of the patients who are currently sitting on my patient panel. And like my 2 previous experiences in residential, I've had pretty radically different approaches to each of these patients. The first patient that I can talk about is a teenager who, for the last 2.5 years, has cycled in and out of inpatient, of various residentials, of PHPs and IOPs. This patient has not formed an identity outside the role of a patient. And I have found myself on the phone with emergency room psychiatrists, with inpatient psychiatrists, and with CL psychiatrists advising about the next step for her. And each time I have consistently advocated for this patient to be discharged to a lower level of care and to not go to the residential or the inpatient center, because I truly think it's in this patient's best interest to be maintained at a lower level of care. This is completely different than the second patient I'll bring up, who is another teenager with treatment-resistant OCD. This patient has tried IOP, has tried PHP, has had ERP therapy twice a week, has had DBT, and I was seeing her relatively frequently for medication management changes. Despite all of this, her symptoms kept getting worse. Her functional impairment was skyrocketing, and eventually I sent her over to McLean. They have a junior OCD residential program. She was there for several months and has just returned. In my correspondence with the patient and with the psychiatrist who discharged the patient, she has made exceptional gains, and her functional impairment is now reduced to the point where she can attend her own graduation and is poised to have a summer job, which are 2 things that were not going to be possible or not even entertainable as options if we had maintained her at her previous level of care in the outpatient world. My third patient is a question mark. I don't know what's going to go on with this patient. This patient is a complicated patient whose diagnoses range from eating disorder, she's been had an inpatient admission for, to polysubstance use, for which she's followed in our UCSF clinic. She's also treated in our DBT, our now comprehensive DBT program with borderline features, and a depressive disorder, for which I also treat her. This is a patient that we had recommended residential treatment for because the patient was not able to stay safe due to high frequency of very risky drug use that wasn't changeable by the initial interventions focusing on the family. However, the patient and family deferred our recommendations for residential up until the time where the patient unfortunately overdosed, and her UDS came back positive for fentanyl, for Percocet, for methamphetamine, and for cocaine. She was acutely psychotic, and frankly, we're all really lucky she survived. She was transferred to a dual diagnosis residential program that specializes in both eating disorders and substance use disorders. And how things go is really unclear. She's been there about a month. So I have these very discrepant personal experiences in residential. I also am across the board in treating my own patients. And I wonder, is there something more? Is there something I should be considering? Or is there something that might help add some structure to how I'm making these decisions regarding this specific higher level of care for my own patients? I turned to ACAP, and while they do have a publication on this, it was last edited 13 years ago. And frankly, it didn't answer the questions that I was trying to ask about when to use residential. And so I decided to do a literature dive to get more data to help inform my recommendations. So to start, I wanted to just revisit some definitions that we're going to be using during this presentation. So like everything in the world of residential treatment facilities, it's a little blurry. People can't even agree on definitions. So what I'm going to present to you is my read of the literature and kind of my gist of what I understand things to be. There is an argument, however, to be made that residential programs are not distinct entities, like I have put on a diagram here. Rather, they're an umbrella term, and that they actually incorporate all of the other types of programs. I think there's an argument to be made that there are distinctive features of each of these levels of care, and I'd like to talk about them for a second. So residential treatment centers specifically offer around-the-clock clinical care for youth with special psychiatric needs, generally at one campus where all basic needs are met. The patients have stable living environments, so individual or shared bedrooms. They have access to bathrooms as well as cafeterias or kitchens. This campus is also where their psychiatric assessments, their therapies, their interventions are conducted. The accredited residential programs have staff medical or clinical directors. And often accreditation is by the Joint Commission, which people may be quite familiar with, CARF, which is the Commission on Accreditation of Rehabilitation Facilities, as well as state-specific social services. Of note, there are a lot of subspecializations of residential programs, as I was talking about before with the treatment-resistant OCD patient that went to McLean's specific OCD program. There are places that specify that they have one diagnosis or therapy type that they utilize, and so specific types of residentials may include those oriented towards OCD, towards substance use disorders. Hopefully, those are the ones that are offering things like medication-assisted therapies, treatments, as well as those that are designed to meet the needs of PTSD patients. There are DBT programs, as well as residentials that specialize in the treatment of eating disorders. There's another type of program that are wilderness programs. These programs place youth in different natural environments, including forest, mountains, and deserts. They seek to remove youth from the distractions of their everyday lives, and they vary widely in terms of settings, of eligibility criteria, of types of activities, duration, involvement of family members, and therapeutic goals. They are grounded in experiential learning. Therapists are generally involved, although the degree of involvement varies widely. Sometimes they're actually leading the kids and adolescents out on the hikes or kayaking, backpacking trips. Other times, the therapists have a specific GPS coordinates that they will drive to, and that's where the kids are setting up camp for the night, and that's where the therapist will meet with the kid out in nature. There's also therapeutic boarding schools. Therapeutic boarding schools are different in that they attract less acute patients. In fact, they're often where the graduates of the residential programs and the wilderness programs are funneled into, although you can directly refer just to a therapeutic boarding school. There's a large percentage of days that are dedicated to academics at these schools. You can expect patients to be earning credits towards high school classes or even graduating with a high school degree. These are longer term programs, generally as short as one academic year, but they can go multiple academic years. And the last program here that I will talk the least about, because it's the least common, is boot camps. These are much less popular. They're often short, sub 1 month programs that are rooted in military exercises, physical feats, emphasizing the respect for authority and obedience as major premise. There's poor evidence of efficacy that caused many of them to shut down or rebrand. And a recent Google search for California boot camps for youth revealed no such programs are currently being advertised in this way. So I would like to spend a little bit of time on the history of how private residential centers emerged, and how so many of my patients ended up having experienced them or touched them at some level. So in 1935, there was an act passed that helped establish foster care system in the United States. And so what this did was take a patient or a child who had previously been housed in an orphanage and had some structural support around some level of psychiatric or behavioral needs, that were met by the large systemic scaffolding around orphanages in general. And with the establishment of foster care, we took youth out of these orphanages and placed them inside the community, often in foster care homes where a small number of children were taken care of by foster parents in the community. Paralleling this, we also had the LPS Act of '67 that helped with the deinstitutionalization effort, which emptied out the large institutions that house both youth and adults. As we all know, unfortunately, community care did not keep pace with the mental health needs that were now evidenced in the community by both the high needs portion of the population who had previously been served by some level of therapy or psychiatry in orphanages, or those whose needs had been met in some way by the institutions that they had previously resided in. We see that public residential centers started coming about around the 80s. And in some cases, they actually took the physical buildings of the orphanages and revamped them into residential centers for children with specific psychiatric or behavioral needs. These programs are where the bulk of the research is. So if you were to look up efficacy or safety or really just about residential programs in the United States, most of those papers would be about this type of residential center. These early centers drew generally the patients that were in these centers were generally the foster care youth who had a high rate of out-of-home placements, had a very high rate of PTSD in ACE events, and whose needs had not been met by the community care that they were surrounded by when in foster care. In the 90s, DBT became mainstream. CBT had preceded that. And we also saw psychiatric prescriptions for youth go up around this time. And the combination of evidence-based treatments like CBT and DBT that were pretty time limited, in addition to increasing use of medication in children, led to this hope that maybe if we combined these things, we might be able to make centers for kids to get better faster. And with a higher degree of effectiveness than what was being reported in the early studies. And so now I'm going to take a little bit of time and focus on those early studies. So overall, this kid shows exactly what was going on with the literature. That early residential centers were absolutely ineffective. 2 thumbs down, maybe. So what we saw was that public residential programs took 3 years to move a child from a clinical to a normal range of functioning. That's way, way too long. That even the kids that made progress in residential programs, when they were transferred to a lower level of care, their functioning declined. So even if the gains were made, they quickly disappeared. And in one study, it went so far as to show that only a quarter, so 25% of the patients who had been in a residential program were maintained in one single less restrictive setting the year after their residential treatment than they had been in the year before their residential treatment. So overall, this really isn't looking good for the efficacy of residential programs. In fact, no words were minced on the opening statement of a special issue dedicated to this. This was penned by Doctors Bennett Leventhal and Patrick Zimmerman back in 2004, and reads that the role of residential treatment seems to have little or no place in the continuum of care for children with mental disorders. Pretty clear cut, right? I wondered if this was the whole story. And then I started coming across literature that sharply criticized the methodologic flaws of these studies, these early studies that were done on the early public treatment centers. Specifically, they cited poor samples, retrospective design, unstandardized measures, the fact that the majority of the studies used only one informant when multiple informants has been shown to be necessary. Of note, a lot of those kids that the early studies were conducted on had a lot of out-of-home placements, and it would have been very difficult to get consistent reports from caregivers about their behavior and symptom burden before and after care. However, other criticisms of this early literature cited that many of these studies used self-styled measures that lacked normative data and psychometric rigor. The sample sizes tended to be small, and very few used advanced statistics to control for error. So what I wondered is that if we have this literature showing that residential programs are generally ineffective, what's going on, and why are they still something that I'm talking about to my patients on a semi-regular basis, at least? Why are there so many around us? We have 2 houses that Newport Academy owns in Marin. We have 2 houses by Muir Woods in Petaluma. We have an Embark One residential center in Walnut Creek and another in Danville. So they're around us. But what's going on? What's this disconnect between what the literature supposedly shows, albeit there are many critiques of it, and what's actually happening? So this is my delve into the literature. Specifically, the most robust study that is out there is this first one that I'm going to talk about. This is a cross-center study. So they use 9 different private centers across the United States. And this was designed as a pre and post study, like most are. I will go into the specifics on the next slide. So in this cross-center or 9-center study, we see that there was about 1,000 kids and guardians that participated in the study. That the average age was 16, 55% were male, which is actually remarkable because the vast majority of the previous studies were heavily weighted towards male demographics, because that's who was making up the admissions to most of the early programs. So the fact that we're seeing 45% of female identifying patients in this study is a big change from earlier. We do, however, see poor representation as far as demographics, with 87% of this population being Caucasian. Also see that SES is not well depicted, with the average median home income of over $100,000 per year. These kids did have an average GPA of a 2.0 upon admission. Psychiatric history-wise, these kids that were included in the study of about 1,000 across the 9 treatment centers, 94 of them had prior mental health contact. Kind of concerns me that 6% of these kids wound up in residential, having never talked to a therapist or met with a treatment provider. So not sure what's going on there, but 94 did have prior mental health contacts. 70% had been tried on at least one medication, and about 1/3 of the patients had been in a psychiatric hospital setting before. They were scored at admission according to two well-known questionnaires. We'll go into more specifics on these on the next slide, but just to paint this in broad strokes, we have something called the Child Behavior Checklist. This is a questionnaire that parents fill out. It's over 100, I think 118 questions that covers a variety of symptoms. And again, we'll go into more detail, but based on parent report, the kids at admission who were at these residential treatment centers scored in the 97th percentile for overall symptom burden. And the kids themselves rated themselves at the 91st percentile. So we see pretty impaired high symptom burdens at admission. When we look at the diagnoses of those that were included in the study, we see that 82% of them met criteria for multiple psychiatric disorders, the most common of which were disruptive mood disorders, substance use disorders, and mood disorders. All right, so this is what I said we were going to go into a little bit more detail. I apologize. I know this is not a fun slide to look at, but I wanted us to actually focus on the numbers here. So what I invite you to do is kind of pick a row, and what we're going to do is go through it. So in broad strokes, what this is, these are depiction of how the kids and the guardians are reporting symptom burden across time. So the first thing we see is CBCL, which is that child behavior checklist. So this is the one that the adults or guardians are rating. The YSR is youth self-report. And we are looking at the scores by different types of scales. So internalizing scales, externalizing symptom scales, total problem scales, which are the ones I just reported on. We also see syndrome scales, so anxious, somatic symptoms, social problems, rule breaking, aggression, etc. What I invite you to do is to just read left to right on a couple of these. I want you to follow what's happening as a patient is progressing through time. So for example, if we pick, let's say, the anxious depressed syndrome scale, what we see at admission is an 8.49 as reported by parents, and a 7.97 as reported by kids. At discharge, which is the next column, we have about halved that, going from 8.49 to 4 according to parents, and down to 4.84 according to the patients. The next two columns are what I find to be the most interesting. This is what's happening after the kids are leaving the programs. So we're seeing at 6 months later and at 12 months later, what is happening to these kids. So what we see is across all of these domains, we see statistically significant decrease in symptoms between admission and discharge. Across all of these, we also see statistically significant symptom reduction between admission and 12 months post-discharge. These kids are maintaining the gains that they made in residential, which doesn't look like what our older studies showed. I would like to point out that there are 3 areas that are a little bit less clear-cut on this study. Specifically, they're the last 3 that are talked about on this chart. They are the attention, the rule breaking, and the aggressive behaviors. What you notice in these is that while there is a significant reduction in symptoms between admission and discharge, between discharge and 12 months later, there is a small spike. So these numbers are actually going up after discharge. However, it is statistically significant, albeit very small, and that the overall decrease in, let's say, the aggressive behaviors at admission of 14.39 or 11.45 compared between the patient report or the parent report, they're still going way down at 5.31 or 7.43. So going down, by we are going to a third of our original score at 12 months later, despite the initial increase between discharge and 12 months. In addition to getting numerical data, They also asked the parents about how the kid was doing at 6 months and 12 months later. And interestingly, at 12 months later, 89% of the patients had remained at home after discharge. They had not been placed in any type of out-of-home care, residential, boarding school, or short-term hospitalization. 86% of the parents reported that their child was somewhat or much better at 12 months after discharge. And the kids themselves, when asked to rate how satisfied they were with their treatment, at 12 months out, they gave it a 4.3 on a 1 to 5 scale, where 1 is poor and 5 is excellent. Next up, I wanted to visit a smaller study. This is a study that was out of the Menninger short-term residential program. This only had 123 participants. And similarly, we will go into some of the specifics about this program. They were about 123 adolescents, average age of 15. Again, really poor representation ethnically, with 87% of this patient population being Caucasian. Of note, we won't go through all of this, but psychiatric history, the patients in this particular study were generally sicker than the ones that I just presented, with about a third of these kids having been hospitalized 3 or more times before their residential programs, and 93% of these kids having at least 1 prior psychiatric hospitalization. Of note also, a difference in study design in the population demographics is that 10% of these kids had psychotic disorders. The most common disorder in this cohort was personality disorders, followed by affective disorders in about 25%. So these are scales that we're now familiar with, the CBCL and the YSR. And in broad strokes, what we see again is that between admission and discharge, which as defined in this paper, the intervention, the residential treatment was exactly 3 months in duration. So you can read the 3 months as discharge time. So again, we see statistically significant decrease in symptom burden between admission and discharge, with the gains maintained at 12 months, which is actually 9 months after the discharge. So again, we see data showing that the gains are maintained. In addition, the study also utilized something called the CAFAS, which is the Child Adolescent Functional Assessment Scale. This was an interview conducted by a trained rater, and it looked at the functional impairment of kids' behaviors across domains. So these domains included, where's the kid self-harming? Was the kid using substances? How was their behavior at school or in the community? Essentially, there are 8 different domains that the children were given ratings on. And again, we see very significant decrease in symptomatology between admission and discharge, with robust gains maintained. I want to bring briefly our attention to some self-published measures by residential programs. These may be things that parents come to you with, as they're easily available on residential's websites. I picked 2 of note. Most programs are not collecting data, or at least publishing the data that they're collecting on their patient panel. So while we should be skeptical of the cherry-picked charts that these places are choosing to publish on their website, it does speak to some level of rigor that they're actually interested in conducting this research at all to see how their kids are doing after discharge. So Newport Academy is one of these residential treatment centers. Their program is generally 5 weeks. That's the reason that these are in 5-week intervals. And here you can see that the PHQ-9 score halves, GAD-7 score goes down significantly from 16 to 9. And then the WHO-5, which is a well-being index, which assesses 5 different tenets of well-being. Each of those, the black bar is, or it might be dark blue, at admission, and then the yellow is at discharge. And so not only do you see that negative symptoms are resolving during the course of the residential treatment, you also see that indexes of well-being are significantly increasing. Similar to Newport Academy, we have a place called Sunrise, which is a DBT adherent program that also self-publishes select data. And I just really want to talk about the first one of these graphics, which is students who no longer struggle with self-harm. It's kind of oddly written. I actually read it the opposite way. It's easier for me to think about the kids who are struggling with self-harm. So if we phrase it like that, 54% at admission are struggling with self-harm. At discharge from Sunrise, only 1% is struggling with self-harm. And the most interesting part of this is that 2 years after discharge, we are at 3% who are struggling with self-harm. So Sunrise is a program that's actually looking at data out 2 years, which is much different than what's happening in most residential programs. Do you want to address some of the elephants in the room as I talk about private residential settings? First of all, you may be thinking, Lauren, Ashley, this is a multi-billion-dollar industry. Why are you spending my time talking about tiny studies and things that residential programs are including in their promotional pamphlets to patients and parents? And it's because there's not a whole lot else out there. And the reason that there's not a whole lot else out there is that we have to follow the money. Who is incentivized to do these studies? I would argue that a lot of these residential programs are disincentivized to be studying what happens in the years that elapse between a patient being discharged and a study report coming out. You might wonder, is a residential center, is it an accurate depiction of the caliber of treatment of a certain program, how a patient 2, 3, 4 years later is doing, because there's no way to know if the patient adhered to any of the program's guidelines or what exactly has come up in that patient's life several years later. I'd also argue that third-party payers who are paying for the vast majority of the private residential treatment centers, they also don't want to prove much efficacy of these treatment centers. There's a report that even when compared to inpatient hospitalizations, residential centers are the most expensive intervention for youth to undergo. And that's because the intensive inpatient hospitalizations have been shortened so much that now the pendulum has swung and that residentials are now more expensive. And so there's not a lot of reason for third-party payers to want to prove the effectiveness of the most expensive treatment modality. We also don't see a lot of negative data, and I wonder if that's because the residential facilities are so protective of their own patient population. They stand so much to lose if their treatments were proven to not be effective, that they don't allow many outside researchers to have access to their data banks, which is a huge ethical quandary. In addition to these, there are structural issues to publishing high quality studies. Things like randomized, double-blind, placebo-controlled, none of those apply in something like this, with residential being such an intensive program. It's not like we could ethically go pick healthy children out of the community and place them in these residential programs and just see what happens for a multitude of reasons. There are structural issues around best types of studies to conduct at residential treatment centers, although there's ways to do this a lot better than is currently out there. In fact, the best studies that I've seen are actually dissertation studies where individual PhDs are doing research about how to compare a residential program versus something like multisystemic therapy or home-based intensive family therapy or DBT. However, these are not yet peer-reviewed, but it does seem to be something of active interest. We also need to talk a little bit about access to care issues. The patients that were included in these studies were patients who could afford to be in these studies in the first place. So we are not looking at a representative sample. The financial burden to getting in these programs generally require private insurance and or self-pay, and these programs can be tens of thousands of dollars per month. And so we have to be very careful about what conclusions we're drawing, and if this is even something that we can is there enough external validity in these studies to apply to our own patient panel. I would be remiss to not talk about the issue of safety that is going on around our residential programs. So this is something that has been increasingly in the press recently. The Governmental Accountability Organization, which I didn't even know existed, became so alarmed by the robust reports of institutional abuse, neglect, and even death in residential wilderness boot camps and therapeutic boarding schools that in 2007, they came out with a publication around this. One of the statistics that they cited was just in the year of 2005 alone, over 1,600 staff members were involved in incidents of abuse. There's a lot of difficulty with communication between the kid and the parents during this time. Phone hours are cut. If you're out in the wilderness, good luck getting in touch with your parents. Things like letters are read through by staff and deemed appropriate or not appropriate to send. There's also difficulties with taking patients at their word or not being dismissive of their concerns. There have been things that have recently brought more voice to these safety concerns. So there's a really well done article or series of articles by the New York Times, by the Atlantic. There's a large nonprofit that was founded by Paris Hilton called Unsilenced. And that organization helped get a bill passed in Utah. So if we look at the bar graph to our bottom right, we see that between 2020 and 2021, there was about a doubling of the rule violations that were filed in the state of Utah by these programs. And one thing that is likely to account for a large degree of this increased reporting is that this Unsilenced group helped pass a bill requiring that residential facilities, wilderness facilities, boot camps, and therapeutic boarding schools recorded episodes of seclusion and restraint as a rule violation, and they actually had to fill that out and file it against themselves. And so that could be something that helps us understand why these numbers are so high. It also draws our attention to just how prevalent things like seclusion and restraints are at these programs. There's also a lapse of accreditation, as we talked about before. So to recap, there's a small number of naturalistic studies that show that private residential programs can be highly effective and maintain robust gains post-discharge up to 12 months generally. Previous data on public residential programs may not generalize to modern private residential programs. There's a huge deficit in publications. There's a lack of representative populations in the studies that we do have. And this field has a very concerning safety record. I will now pass the totem to Dr. Schaller for her expert opinion on what to make of all of this.
Thank you, everybody. And thank you, Lauren Ashley, for that very thorough review of a very scant area of our literature. So I have way more thoughts than I can talk about in 10 minutes. This mic is the mic popping in and out, or can people hear it consistently? It's okay? Okay, great. Just way louder than I expected it to be. And I'm getting feedback. So next time, I guess I have to do Zoom. We'll see. I wanted to say first that I could talk about this for 3 hours. So if people have other questions, please come find me. That's totally fine. But I want to try to attempt to answer your questions, Lauren, Ashley. And I think ultimately this will come as a surprise to nobody that I say this, it's a dialectic, right? So this is a very, very messy area, not just because the data is incredibly poor. And I just want to underscore again how poor this data is. If this was a new psychotherapy, I would not use it because it would be highly experimental. It would be a last resort for a patient with that particular symptom profile. So this is really very little to base this entire system of care on. But the problem is our entire system of care is very, very messy, right? And so I'm going to go through some of the questions that I ask in the rare cases where I might recommend residential. And kind of where I sit is I almost never recommend residential, and I really try to dissuade families from it. And sometimes I feel like I have to. And that's because of some of the problems with our system. And that's where I want you all to sit. But I do also want to be clear that it's very, very messy. And I think it's part of our ethical duty to be transparent with families that it's very, very messy. So when people ask me like, well, what programs do you recommend? I'm very clear that I actually can't recommend strongly any programs. I will put together a list of the places that most recently I've heard some pretty good things about, and that changes constantly. And it's very difficult to see inside these places. It's very difficult to know what's truly happening and what's going to be good for a particular patient versus other patients. So given that we have a broken system, and given that it's very, very difficult to make this decision, I wanted to highlight just a couple things. So one was that previous contact with psych services that the cross-center study highlighted. That's defined very broadly by programs and in that study as well. So that might mean that they spoke to a school counselor who recommended that they need additional care. It might mean that they had an ER visit where a psychiatrist did an assessment. There are a lot of kids, and we see them frequently in our DBT program, who get sent to residential after 2 hospitalizations without a good outpatient trial of any kind. So that's my first question is, has this kid actually accessed evidence-based outpatient care of any kind in any consistent way? And while they may technically meet the criteria of contact with psych, that's often not the case. They've often been passed in sort of an emergency way. They've had, say, 3 inpatient stays in a row, and the inpatient team is like, this isn't maintainable. They should go to a higher level of care. So that's one thing. Of course, that means that it's really, really hard because some kids don't have access to that, right? We have a therapist shortage. We have a lot of people that don't have access to treatment for a wide variety of reasons. So I'm not saying that like, gosh, why aren't you sending them to outpatient? I know people are trying very hard to do so, and sometimes it's not an option, right? The other thing that I really pay a lot of attention to is what's going on with the family. So one is parents very reasonably often have the misconception that more is better, right? So the promise of these clinics is very high, right? Like, oh, well, it's like being an outpatient, but you do it all at once and you do more. And so sometimes people are like, oh, well, we'll just do this for the summer, and then my kid will be back in their junior year and things will be normal. And for some things in life, more is better. But when you think about adolescents, who the vast majority of people going to these are adolescents, their developmental tasks are here, they're at home, right? There are things that they need to do here, and they need to be practicing those things in real life. So doing something more quickly does not necessarily mean that it's better. We want to try to make sure to get that high quality care closer to home if it's possible. The other thing I want to know about the parents is, how are they doing? Are they so burned out, or are they so impaired that they actually cannot keep this child safe? And sometimes that is a situation that you'll see, right? And then maybe they have been trying the outpatient program for a while, or there's something else going on with that parent. They have their own mental health challenges, or they have systemic challenges that are beyond them, and there is not a way for them to provide the level of supervision and the level of skills practice that this kid will need to improve on their own. That's a time where I might consider residential as well, especially when, and some of these better ones do a lot of family involvement over Zoom or in family weekends and things like that. So those are when I have to do it. Those are the reasons that I will consider it. But unfortunately, it's not very common because it's just, there's still such a black box. And I appreciate you acknowledging, Lauren, Ashley, that these are hard studies to do, right? And I think these dissertations are more promising in terms of actually comparing a residential program to something else. And we don't have any of that. We have nothing that is remotely randomized. And yes, we can't just send a bunch of kids to residential, but if you could design a nice study where you're in a particular catchment area and kids who are high risk either get randomized to, say, a comprehensive outpatient DBT program or this outpatient residential program, and they're offered by the same place, and you're looking at the outcomes for both. But no one has done that study, and there are a lot of economic disincentives to doing it. So I think the take homes I want you to have are, the data is garbage. It's truly terrible. So please do not make promises to parents. And sometimes it's something that we have to try because we don't have any other options. I'm hoping that there's some trainees that are listening to this that are inspired to think about designing more elegant studies and think about really looking into this, because it's a huge problem in our field that I think is only going to continue to grow. And we're in the middle of this child mental health crisis with suicide on the rise and all kinds of new heights of clinical anxiety that we hadn't seen prior to the pandemic. So this is going to keep coming up, and it's going to continue to be a challenge. And those are the main things that I have. And then I think we probably have like 2 minutes for questions for me or Lauren Ashley. Great.
It's incredible. You both covered a huge amount of ground. So thank you. So we have a couple of questions from Lauren Stiller. Would you mind unmuting if you're still with us here to ask your question or your comment?
Well, I'm out in private practice in Walnut Creek. Can you hear me? Okay.
Yeah, we can.
And I have occasion to have to find a alternative setting for treatment. I'm mixed about this, but my experience is that the school districts will often be called upon to pay for a portion of the costs of the residential therapeutic schools. I would like to get your opinions on that. And just to mention, there are a number of private companies who do evaluations and recommend specific settings. They do have knowledge of the settings, and a couple of them do post-discharge wraparound care, but they're all very expensive.
Yeah, Lauren Ashley, do you want me to take that one? Yeah, okay. Thank you. These are really important questions. Okay, so I'm going to take them in reverse order. So I think you're talking about educational consultants. And I have really mixed feelings about this. They have the advantage of going into settings, of course, and actually seeing what's there. And it is very, very expensive. It is out of reach to all but a couple of patients that we see in our DBT program, certainly, and the people in our DBT program have commercial insurance. So it's completely out of reach to people who are uninsured or on Medi-Cal. And there have definitely been situations where educational consultants are receiving payments for the people that they send to particular programs. There was a couple newspaper articles about this, probably about 10 years ago. There was in the mid 2010s, this was a huge area of skepticism. I have heard that the profession has cleaned up and that there are standards, but I will plead ignorance to those specific guidelines. But that is the concern, is that sometimes the recommendations are not necessarily only based in what would be best for the child. They're also based often on a separate assessment. And I have seen many educational consultants that do an assessment without actually meeting with the child. So the assessment is with parents and teachers and with a former therapist and not with the kid directly. I hope that it's self-evident why I would be concerned about that. In terms of the school district, this is a huge area, and this is, I'm really glad you brought this up. Often for kids in our DBT program, they have been sent to residential by their school district before the kid has ever had a chance to access high quality outpatient care. So depending on the pipeline that you go through, some kids will get referred to residential, like in the cases of Lauren Ashley's panel, they're already engaged in some form of outpatient care, but it's not enough. Some are sent straight through the schools through an IEP. So the kid is classified as severely emotionally disturbed. They've tried a counseling enriched classroom. They've tried an alternative setting, and the kid is still not succeeding academically due to emotional or behavioral problems. Then they'll consider a residential program. Often the school district has a particular program they're contracted to. So all the kids go to that program or one of 3 programs, and it's really not tailored to the specific needs of that specific kid. So with Lauren Ashley's, OCD miracle story, that kid would not be sent to the program that best matches their needs. They're sent to the one that school district happens to contract with. And I am biased by this by my love of the literature, but I'm also biased because I run a DBT program and I hear about the trauma inflicted by residential programs on a weekly basis from kids that have been sent to these programs that are run in a non-evidence-based manner and that don't take into account the specific needs of each individual kid.
I wish we had more time. Maybe we
And
need
you
a
can
consult.
ask me your question.
Yeah, it's a great question. Maybe Dr. Schaller, you need to start a consultation group around this.
I mean, it's mostly just me telling you not to do it, but
wonderful talk. Thank you both, and have a great afternoon, everyone. And
thanks everybody.
yeah, take good care.